thought it was interesting, and that patient case really stuck with me. So I just wanted to educate other pharmacists about what GPA is. If you see on this picture that I have on the front screen, you'll see that it actually GPA affects a lot of organs. Most particularly, this disease typically starts in the lungs and then it affects other organs. So I have no financial interest or disclosures. And I just wanted to thank Tyler for co-authoring my CE. Okay. So some pharmacist objectives that we're going to learn in this CE, just define what GPA is, describe the signs and symptoms of GPA. We're going to talk about complications that's associated with GPA, and then we're going to talk about treatments for GPA. So before I jump into what GPA is, I'm just going to first talk about what antibodies are, because antibodies have to do with the disease state. So antibodies are a Y-shaped protein made by plasma cells in response to an antigen. So what are plasma cells? They're terminally differentiated B cells that are capable of secreting an antibody. And then what's an antigen? It's a substance that causes the body to make a specific immune response. So basically each antibody can only bind to one specific antigen. And the purpose of this binding is just to help destroy the antigen. Some antibodies destroy antigens directly, while the others will make it easier for white blood cells to destroy the antigen. I do have a picture of an antibody on the top right. So it's just a Y-shaped protein and it's showing an antigen attaching to it. So now we're going to jump into the background of GPA. So GPA, also formerly known as Wegener's disease in the past, it's a rare disorder that is characterized by small medium vessel necrotizing vasculitis. So this rare disorder is actually under the umbrella term of ANCA-associated vasculitis, also known as anti-neutrophil cytoplasmic antibodies. So ANCA-associated vasculitis will be like the umbrella term, and then there's other disease states that fall under it. So GPA is one of them, but there's other disease states that I'll briefly mention that fall under these associated vasculitis disorders. GPA does result in damage to various organs of the body, and like I previously mentioned, it does start with the respiratory tract and kidneys. So just to have a brief background on what ANCA are, because I just mentioned it. So they're autoantibodies that target neutrophils, and they are harmful autoantibodies that are going to have a direct damage on the small blood vessels. It's not really known how ANCA arise, and I guess the etiology of it is poorly understood, but infections are one possible trigger that researchers are saying for a rise in ANCA. And then another proposed mechanism is molecular mimicry, which basically is when foreign and self-antigens, they're so similar that it's sufficient enough to activate an immune response. So just continuing on what ANCA are. So basically this whole mechanism shows how ANCA, or the rise of ANCA in the body, causes vasculitis. So basically the ANCA will bind to neutrophils in the blood, and that results in release of toxic substances from the neutrophils that causes damage to small blood vessel walls. And then neutrophils will migrate to this inflammation area, and then it will cause inflammation in the surrounding tissues. And then signaling factors will be released that attract more neutrophils, and it just perpetuates the inflammation. It's like a downstream effect of inflammation and destruction of small blood vessels. And then I do have a picture at the bottom that just shows the mechanism that I just talked about, but basically ANCA they cause an inflammation of the vessel wall, and that leads to vasculitis. So this is the AAV disorders that I was talking about earlier. So that's like the big umbrella term. And then GPA falls underneath it, but so does microscopic polyangiitis. And then eosinophilic granulomatosis with polyangiitis, also known as EGPA or Churg-Strauss syndrome. So all of these fall under the vasculitis disorders. So I'm just going to describe some typical characteristics of MPA and EGPA just briefly. just to mention it, I will be focusing on GPA for the rest of the CE, but just to describe them a little bit in case anyone's curious. So MPA has to do with microscopic polyangiitis. So that has to do with like microvasculature and like microvessels. So like when I think of that, I think of like joint pain, peripheral neuropathy. So those are common symptoms that are associated with MPA. And then EGPA, also known as eosinophilic granulomatosis with polyangiitis. So a common sign of EGPA is adult onset asthma. And then these patients can also have an elevated count of eosinophils as well. So just to reiterate, I will just be only focusing on GPA, which does fall under the ANCA vasculitis disorders. And just wanted to mention MPA and EGPA in case anyone was curious. So now we're going to jump into some statistics about GPA. So who gets GPA? This rare disease is estimated to affect 3 out of 100,000 people. It's most often occurs between the ages of 40 and 65, but it could also occur at any age. It is rare in kids and it affects women and men equally. Next, we're going to talk about the etiology of GPA. So the exact cause of GPA is not completely understood. And then most researchers that research this disease are presuming that the ANC are actually responsible for the inflammation in GPA. And that has to do with the mechanism that I just described earlier and how ANCA like leads to vasculitis. Now we're going to talk about some pathophysiology of how GPA comes about. So it has to do with granulomas. So granulomas are a type of cellular inflammation that are usually seen on biopsies of affected organs. So on the left side, I just have a picture of granulomas. So granulomas, unlike the ones in like sarcoidosis or TB, they consist of giant cells surrounded by plasma cells and lymphocytes and dendritic cells. So the inflammation will lead to lack of blood flow in the small blood vessels, and that leads to lack of oxygen. So basically the blood vessels are not getting blood flow and oxygen, and that can lead to the granulomatous inflammation. The granulomas in GPA ultimately result in partial or total occlusion of blood vessels. So in severe cases of GPA, necrosis and permanent deformities can occur because of the fact that there's just constant inflammation that's penetrating to the surrounding tissues, and granulomas have formed that have occluded blood vessels now. So now that we discussed the statistics, pathophysiology, and etiology, we're just going to jump into the symptoms of a patient presenting with GPA. So these are just generalized symptoms of GPA, very nonspecific. So fever, malaise, myalgia, polyarthralgia. So the disease starts off with muscle pain and these nonspecific symptoms, and then it can progress to like necrosis and deformities, like I just talked about. So an initial symptom of joint and muscle pain makes sense, since I just talked about granulomas and inclusion of blood vessels. So that will lead to just lack of blood flow and lack of oxygen to the muscles, leading to muscle pain. And then these nonspecific symptoms aren't enough to diagnose someone with GPA, as many conditions have the same initial symptoms. GPA affects many different organs. So having these symptoms and multi-organ system involvement can lead us to a better direction and diagnosis of GPA. And then now we're just going to talk about organ systems with GPA. So this is just an overview on the most common organs affected. So like I mentioned briefly before, GPA typically starts out with like the respiratory tract involvement. So just focusing on that, 90% of patients have upper respiratory involvement. So they're showing up with symptoms of, otitis media, sinusitis, nasal and sinus pain, facial pain, sinus stuffiness. They can have nosebleeds, ear infections, and then the constant inflammation can actually lead to like septal perforation and septum necrosis. So the presence of clinical signs of sinusitis, cresting rhinitis, ear infections, and hearing loss should alert someone for GPA. And then, so this is just a picture just showing more of like the respiratory tract involvement, but also like the tracheobronchial involvement, which is basically stenosis of the trachea and bronchus, which leads to airway obstruction, which is very serious because that will lead to a patient not being able to breathe. And then there can be also nasal bridge collapse with the septum erosion and necrosis. So I have a slide on that next. So saddle nose complications, just to show you a picture of what a saddle nose looks like. On the top, they have like a collapsed bridge and the bulbous tip. And then, so that's what a saddle nose is. And then GPA can progress so severely that actually patients can have loss of their septum because it just becomes necrotic and comes out in pieces, to be honest. So some complications of saddle nose notably is an infection, because if you have septum erosion or septum necrosis and don't have a septum anymore, then that's serious, because then you're at an increased risk of an infection, because our septum helps to basically, warm the air that we breathe and filter the air from the pathogens. So if you don't have a septum anymore, then that will lead to an increased infection and will lead you to have like some sort of infection in your nose. So just going along with more of the respiratory tract involvement, now I'm talking about the lower respiratory tract involvement. So some symptoms that a person would have with this would be dyspnea, cough, and nearly 50% of patients present with bilateral or unilateral pulmonary infiltrates. And then, like I mentioned before, with the trachea and bronchus, there could be stenosis, and that's a serious complication because there would be a narrowing of your trachea and bronchus, and that could lead you to having shortness of breath or just not being able to breathe. So now that we covered GPA and how it affects the respiratory tract, let's talk about how it affects the other organ systems. So with kidney involvement, there could be glomerulonephritis, and that eventually develops in 80% of patients, and it leads to CKD or ESRD. There can also be ocular involvement, and it's most commonly seen in more than half of GPA patients, and they can have conjunctivitis. They could also get PUK, which is peripheral ulcerative keratitis, and that's the most significant coronal complication of GPA. There could also be hearing involvement, so you could have hearing loss due to auditory tube dysfunction, and that's noted in many cases of GPA. There could also be skin involvement, so patients, 50 to 60% of patients can have purpura and involving the lower extremities, and they can also have cutaneous nodules. So now that we talked about the organ systems that are involved with GPA, let's talk about the diagnosis. Oh, wait, no, not yet. So there's also central nervous involvement. So that's 30 to 40% of patients that could have peripheral neuropathy. There could also be seizures that have been reported. And then, like I briefly mentioned before, a lot of GPA patients have like muscle pain. So the presence of joint pains, subcutaneous nodules, and rheumatoid factor positivity can often lead to a mixed diagnosis. So that's important because if these patients are presenting with those nonspecific symptoms and then they have some sort of organ involvement, that can commonly be misdiagnosed as another rheumatoid disorder. And then that actually leads to like delays in treatment because now they're initially being misdiagnosed with another disorder, and then it kind of goes back and forth. So just something to note. So now we're going to talk about diagnosis of GPA. So there's not really one diagnostic criteria with GPA. There's not really one test. It's a culmination of like symptoms, physical examination the patient's presenting with, lab tests such as urinalysis or blood tests, imaging studies, and then most physicians will recommend getting a biopsy because that can help confirm the diagnosis. And then just to note that many conditions could mimic GPA and have to be ruled out before a final diagnosis can be established. And this just goes back to the fact that like this can lead to misdiagnosis, and then initial treatment or the proper initial treatment is delayed. So these are just some conditions that can mimic GPA besides the ANCA associated vasculitis disorders that we talked about. So you have the autoimmune disorders like SLE or rheumatoid arthritis. You can also have infections that mimic GPA, such as sepsis or infective endocarditis. There could also be malignancies that mimic GPA, such as lymphoma. So just continuing on the diagnostic criteria. So there's also a blood test done for ANCA, and this test just checks for the antibody in your bloodstream. So if a blood test is positive for ANCA, that just means that you need to do further examination for the patient. A positive test doesn't mean that doesn't confirm a diagnosis, but a negative test does not rule out GPA either. A tissue biopsy is definitely still needed to confirm diagnosis. So as we can see, that this disease is not really easily diagnosed, and it usually requires an experienced rheumatology doctor so that they could, so there can be delays in appropriate treatment given the difficulty of diagnosing this disease. So now that we have a solid background on GPA, we're going to be talking about some treatments for GPA. So the treatment criteria, so there's chronic inflammation in the blood vessels, and that can just lead to organ failure. So without proper treatment, GPA can actually worsen rapidly, and it leads to potentially life-threatening kidney or lung failure. And treatment choices are really based on the organs affected, disease severity, and individual medical factors. So I'm just going to be describing the disease severity as defined by the American College of Rheumatology. So the American College of Rheumatology, they define active disease as new or persistent or worsening clinical signs attributed to GPA. Then you have severe disease, and that has to do with vasculitis and life or organ threatening manifestations. So that includes glomerulonephritis or cardiac involvement. There's also non-severe disease, which is vasculitis without the life or organ threatening manifestations. So that's like asthma and rhinosinusitis. Remission is basically absence of clinical signs or symptoms. Refractory disease is persistent active disease despite an appropriate course of immunosuppressive therapy. And then relapse would be recurrence of active disease. So just continuing on with the treatment. So the treatment of GPA involves the use of immunosuppressive agents, like in combinations. So treatment is classified into two phases, the induction phase and the maintenance phase. So the induction phase is basically the first treatment given for a disease. Maintenance would be after the induction phase. So that's when the induction phase is given for a period of time and the patient is responding well to it. So then now you can switch them to the maintenance phase. And then commonly used agents in treatment of GPA are cyclophosphamide, rituximab, methotrexate, glucocorticoids, and plasmapheresis if indicated. So first, we're going to jump into the treatment options in terms of induction phase and maintenance phase. So we're going to talk about active severe disease first with remission induction. So active severe disease with remission induction. So what choices do we have? We have cyclophosphamide first line with a glucocorticoid. You can also use rituximab with glucocorticoid as a first line treatment as well for severe GPA. The choice is really based on the patient preference, provider preference, and adverse effects associated with each of these medications. So just continuing on with active severe disease. So plasmapheresis can also be used in active severe disease. And what is plasmapheresis? It's basically a procedure in which a machine will separate plasma from the blood cells. The plasma is then discarded and replaced with colloid fluid. And then it's combined back with the cellular components and returned to the same patient. So plasmapheresis is often done to remove extra antibodies and other harmful substances from the blood. And then indications for plasmapheresis in terms of GPA are basically when a patient has rapidly declining kidney function or pulmonary hemorrhage that does not respond to IV glucocorticoids. So next we're going to be talking about a trial called the RAVE trial. So this was basically just looking at cyclophosphamide with glucocorticoids plus rituximab with glucocorticoids, because like I mentioned in remission induction, both of the combinations can be used as first line, and it's because of this trial. This trial was done in 2010, so some background on it. Cyclophosphamide and glucocorticoids have been the standard therapy for remission induction for a long time. So the primary endpoint of this study was remission of disease without the use of prednisone at 6 months. So the methods for the RAVE trial was multi-centered, randomized, and a double-blind non-inferiority trial, looking at rituximab plus glucocorticoids compared to cyclophosphamide plus glucocorticoids for remission induction. So just talking about some results. So 99 patients received rituximab while 98 received cyclophosphamide. Looking at the rituximab group, so 64% reached the primary endpoint, and then 53% in the cyclophosphamide group reached the primary endpoint. So this result showed non-inferiority. There was also a subgroup analysis in the patients with relapsing disease at baseline done, and 67% of patients in the rituximab group compared to 42 reached the primary endpoint. So that just showed that rituximab-based regimens were actually more efficacious than the cyclophosphamide-based regimens for inducing remission of in patients that had relapsing disease. So in conclusion, rituximab therapy was not inferior to daily cyclophosphamide, and rituximab may be superior in patients that have relapsing disease. So now we're going to just talk about remission induction for active non-severe disease. So in patients without severe disease and no contraindication to methotrexate in combination with glucocorticoids is used. So that's like first-line remission induction for active non-severe disease. And now we're going to just talk about maintenance therapy once remission induction is achieved. So maintenance therapy is initiated after induction of remission is achieved, and that's usually about 3 to 6 months. And then patients are transitioned to maintenance therapy to avoid relapses. Effective options for maintenance therapy are methotrexate, azathioprine, and rituximab. And then duration of maintenance therapy usually has to do with the patient. So it could be 12 to 36 months, or it could be even longer or indefinitely in patients who are at high risk of relapse. So other factors that influence the choice of the maintenance agent that's going to be used include a prior history of toxicity or comorbidity that increases the risk of toxicity to a particular agent. Just to note that the dosing of rituximab is different in maintenance therapy versus the remission induction. And it makes sense to use methotrexate, azathioprine, rituximab, because these are all anti-inflammatory agents. So you want to just keep using anti-inflammatory agents even in maintenance to keep the vasculitis at bay. So other therapies for induction maintenance. So this is for induction and maintenance. So this could be mycophenolate, cyclosporin, IVIG, or Bactrim. And I'm not going to be really going too much in depth into these therapies, but just wanted to mention them. And then so I just wanted to mention for Bactrim that the guidelines actually recommend a lot of other therapies over Bactrim, and they state that Bactrim may only have a benefit for patients that have sinonasal involvement. The guidelines actually recommend using a lot of other therapies over Bactrim just because Bactrim has the severe hypersensitivity reactions, and it does have a drug-drug interaction as well with methotrexate. So that's just something to note. So I just have a screenshot of the algorithm that's used in treatment of GPA, active severe versus active non-severe from the guidelines. So just looking at the left side, from the guidelines, actually rituximab is first line and preferred over cyclophosphamide. But in practice, I've seen, or in my research as well, I've seen cyclophosphamide plus glucocorticoids be used more often, just because rituximab does have that infusion reaction that's really common with a lot of patients. So rituximab with glucocorticoids or cyclophosphamide with glucocorticoids, they're both very good options for remission induction for active severe disease. And they're both options because of the RAVE trial. If you just go down this flow chart, you can see that rituximab is really commonly used in remission and relapse. So it's very common on this whole flow chart, and that's because of the RAVE trial, because the RAVE trial showed that rituximab was superior in patients that had relapsing disease. Just looking at the left side or the right side, active non-severe GPA. So like we mentioned before, glucocorticoid plus methotrexate is preferred over the other combinations. And then if you're just looking down the flow chart, methotrexate and rituximab keep showing up. They're very good options for remission and relapse. So that's just something to note. So now I'm just going to jump into talking about how certain drugs work. So I'm going to focus on rituximab, cyclophosphamide, methotrexate, and glucocorticoids because those are the commonly drugs used in treatment of GPA. So just looking at how rituximab works, it's a monoclonal antibody directed against the CD20 antigen on the surface of B lymphocytes. So rituximab will bind to the antigen on the cell surface, the CD20, and activates a complement-dependent B cell cytotoxicity that leads to cell killing. And then just looking at administration of rituximab pertaining to GPA. So rituximab, as we all know, is IV only. It does have the common infusion-related reactions that occur. So you want to slow down the infusion rate or discontinue the infusion if you're giving a patient rituximab and develop a reaction. I have the dosing from the guidelines that's used in GPA. So in terms of giving rituximab to patients that have GPA, you want to pre-medicate them with Tylenol and antihistamine and methylprednisolone in the case of treating a GPA patient with rituximab. And then just something to note, but this medication could be a burden for patients just because it is IV and it has to be given in an infusion center, and it usually takes about 8 hours of infusion chair time. So that's just something to know because patients might not have that much time, or they might not be able to get to the infusion center. So when we're picking treatments for patients, we just want to be mindful of that as well. And maybe they might prefer cyclophosphamide. So how does cyclophosphamide work? It's an alkylating agent that prevents cell division, and it decreases DNA synthesis by cross-linking DNA strands. Cyclophosphamide reduces inflammation by suppressing the immune system. And just to know, cyclophosphamide is very commonly used in DLBCL, and it's effective at killing B cells. So in terms of administration for cyclophosphamide, it's given IV pulse. I meant to write IV pulse or oral. And this is the dosing scheme on the bottom. So you can give the oral for 3 to 6 months, or you could give IV every 2 weeks or for every 3 weeks for at least 3 doses. Cyclophosphamide is associated with a moderate to high emetogenic potential. So you might consider giving a patient like an antiemetic regimen before giving them cyclophosphamide. And then a common side effect of cyclophosphamide is hemorrhagic cystitis. So next, we're just going to talk about how hemorrhagic cystitis actually happens with cyclophosphamide. So how does hemorrhagic cystitis happen or how does cyclophosphamide cause hemorrhagic cystitis? So during hepatic metabolism of cyclophosphamide, acrolein, which is a toxic metabolite, is generated. It's going to be filtered by the kidney, and then it becomes concentrated in the bladder. Acrolein is urotoxic, and it can lead to ulceration of the bladder mucosa. So how can we just decrease hemorrhagic cystitis occurrence with cyclophosphamide? You can increase the fluid intake that the patient is intaking, like give them more fluids. So that would be during or for 1 to 2 days after the cyclophosphamide. We can also use Mesna, which is a thiol compound that inactivates acrolein. And it does that by binding to acrolein and forming an inert thioether, which is able to be excreted. And then you want to use Mesna in patients that are receiving high-dose cyclophosphamide. Use of Mesna in lower-dose cyclophosphamide isn't really warranted, but could be used. And then in terms of monitoring, cyclophosphamide is renally cleared. So we just want to be mindful of the patient's kidney function, as GPA does lead to kidney failure eventually if the disease isn't controlled. So how does methotrexate work? Just mechanism of action of methotrexate. It's a folate antimetabolite that inhibits DNA synthesis, repair, and cellular replication. So how is methotrexate an anti-inflammatory? So it basically works by inhibiting this enzyme, which will increase intracellular and extracellular adenosine, which is a purine nucleoside with anti-inflammatory properties. And then how is methotrexate administered for GPA? So per the guidelines, you use 25 milligrams per week, and that could be subcutaneous or oral for remission induction. I also just listed like the other routes that methotrexate comes in, like oral tablet or IM or IV. but you wouldn't be using these routes. You would just be using subcutaneous, methotrexate, or oral. And then methotrexate does have drug interactions that you want to be mindful of, such as Bactrim, like I mentioned before, but also it has an interaction with NSAIDs. And like I mentioned before, patients that have GPA are commonly presenting with myalgia and arthralgia, and they might be taking NSAIDs. So that's just something that you want to counsel the patient on and be mindful of. And then methotrexate is also renally cleared, so just want to be mindful of the patient's kidney function too. And then how do glucocorticoids work? So they decrease inflammation by suppressing the expression of pro-inflammatory cytokines, and they also reduce the activity of the lymphatic system. So this all of it leads to suppression of the immune system. How are glucocorticoids administered in patients that have GPA? So per the guidelines, you can give IV methylprednisolone, or you can do high dose oral glucocorticoids. And then I just noted that prednisone does come in different formulations, but you're just going to be using IV methylprednisolone or high dose oral glucocorticoids, whichever one you choose. So now that we discussed the mechanism of actions of all of these medications, as well as the administration, we're going to be talking about toxicities and side effects associated with these therapies. So starting from the top left, these are just notable side effects of these therapies. So black box warning for rituximab is hepatitis B reactivation, PML, and infusion-related reactions. For cyclophosphamide, what comes to mind is like bone marrow suppression, cardiotoxicity, hemorrhagic cystitis, like we discussed. For methotrexate, you could get SJS. There's bone marrow suppression with methotrexate, as well as exacerbation of hepatitis B. And then I also focused on prednisones because that's the most commonly glucocorticoid used with GPA, but some common side effects with prednisone would be like weight gain and hypertension and diabetes. So now we're going to talk about what it's like to have a patient that's like living with GPA. So GPA is a very challenging disease to live with because, you know, you have chronic inflammation, you have chronic fatigue and pain, and that could just lead to emotional stress, and it can take a toll on a patient's well-being. It can affect a patient's work and personal relationships. And then due to the multi-system organ involvement that we talked about, patients must have multiple healthcare providers. And it's really important that they're following up with these multiple healthcare providers just to make sure that their disease is being managed properly. It's also really important for all these providers to communicate with each other so they're all on the same page in terms of how the patient is doing. And then regular doctor visits together with monitoring laboratory tests and imaging studies can help detect relapses early. So what's the prognosis for GPA? So GPA is associated with significant morbidity and mortality because of the fact that you're on a prolonged use of glucocorticoids, and also you're getting prolonged use of immunosuppressive agents. And then there's also just the fact that there could be irreversible organ damage with GPA. So all of these things can lead to a poor prognosis. So the average life expectancy for a patient with GPA without any treatment is 5 months, which isn't a long time, and with a 1-year survival rate of less than 30%. But nowadays, because of the fact there's like GPA guidelines and people are doing research on GPA, and there's established treatments, 80% of patients who are treated are alive for at least 8 to 9 years. And then just to know, but patients with severe renal involvement will have a higher rate of mortality just due to the fact that they have decreased therapy options. So I'm talking about like cyclophosphamide and methotrexate, just because they have to be renally dose adjusted, and patients that have really bad renal function can't use them. So plasmapheresis would be an option for patients that have a severe renal involvement. So they just have less therapy options to choose from. So GPA is just a multi-system disease that requires a collaborative effort. So just to discuss some interprofessional collaboration. So again, like I mentioned before, so like there's many different type of healthcare providers that are involved in taking care of patients with GPA, such as rheumatologists and pharmacists and nephrologists, that we all play an important role. And it's really important that all of these healthcare providers are communicating just so the patient is getting the best treatment that they can and they're stabilized properly. And then just to know, but nurses also play an important role because they're giving or administering the drugs. So they're doing the vital checks and measuring the urine output. And they also provide immediate care to the patient if they're having an infusion reaction and just monitoring them closely. So nurses do play an important role. But how can pharmacists play an important role in treating GPA patients? So pharmacists can be tremendously helpful in treating patients with GPA. So by just aiding in compounding and dispensing of the chemotherapy agents, as pharmacists, we're monitoring for toxicities and coming up with a management plan for the said toxicities. We're calculating and recommending the appropriate doses for the therapies used. So if the patient has renal involvement, we're going to be renally dose adjusting the drugs for them. And then we're also monitoring for drug interactions associated with these therapies. So now that we talked about GPA and I covered pretty much everything, let's dive into a patient case. So I'll just read the patient case, but you guys can just read along with me as well. So NB is a 34-year-old female that's presenting to the outpatient clinic, complaining of facial fullness as well as post-nasal drips and sore throat. So at the time, she is treated with antibiotics for sinusitis with questionable improvement. So 2 months later, she comes back and now she's complaining of intermittently blood-tinged nasal discharge and receives another course of antibiotics with no improvement. Another month later, NB comes back to the clinic and now she's complaining of chest discomfort and shortness of breath and hoarseness and difficulty speaking. So now she's evaluated by rheumatology and blood work and a nasal septal biopsy is done. So these are the labs that we have. So just to note, the patient isn't pregnant. She does have a positive ANCA blood test. And the biopsy results show granulation tissue with scattered giant cells and vasculitis. It's seen. Patient does not have any allergies. And so the diagnosis is the culmination of NB's clinical signs and symptoms, biopsy, and lab results suggest a diagnosis of GPA. So I'm just going to have 2 questions coming up about this patient case. So question 1, does this patient have active non-severe GPA or severe GPA? You guys can write in the chat if you want. I'll wait a little bit. So because of the patient case that I went over, the patient has active non-severe GPA, just because of the fact that she's just presenting with like those initial signs and symptoms. And the disease is very localized just to the septum and there's no multi-system organ involvement. So it's a active non-severe GPA. And then question 2, which therapy is recommended for remission induction for active non-severe disease, A, B, or C? You guys can write in the chat and I'll give you guys a second. So the answer would be A, just because, like I mentioned before, the patient has active non-severe disease. So you would treat that for remission induction, you would treat that with methotrexate and glucocorticoids. And then B wouldn't be the right answer because rituximab and glucocorticoid, that's in a remission induction for active severe disease. And then C, you don't use methotrexate alone. So that's just not an option. So just conclusion, so GPA is a rare disease that affects multi-organ systems. It's really hard to make a diagnosis right away, and that's why our patients are usually misdiagnosed at first. And again, like I mentioned, that just leads to delays in treatment because they're not being treated properly for the right disease. There is no cure for GPA at this time, but early diagnosis and effective treatment can bring the disease into remission, and many patients can lead full and productive lives. And that was all I had. Does anyone have any questions? You can please write in the chat. If not, I can just email you guys my slides and then email you guys the questions, and then I can send you the CE code once you guys send me the answers. But that was all I had. Thank you. Thanks, everyone. I'm going to be closing out the meeting, but if you have any questions, you can always email me. I'll wait a little longer if anyone has any questions, but I will be emailing the slides and the questions, and then you guys, I can send you the CE code. Thank you.